want that first time for you to get freaked out and not understand what to do, okay? So the whole idea of today is to really practice with each other, ambulating and I don't feel very well and kind of fainting, okay? Now we're only gonna faint on the mats, okay? Not on the floors, please. I don't want anybody to get hurt. And we're gonna practice with, you know, the tall people with the shorter people with the taller people, whatever. We're gonna mix it up so that you can see what it's like for all kinds of, body shapes and things like that, okay? Now, when you are walking with someone, you naturally have a wide basis of support, right? And so that should always be in your mind, to always have a wide base of support. I like to have my lateral leg forward, okay? And I'm like this. If I need to, I can always pull someone back. You never want the patient, you never want to try to catch someone going forward because you're going to hurt yourself, okay? You remember what your erector spinae looks like? Okay, not so strong, right? So, your first thing you want to do is you pull them back to you. Now, if you have someone following with a chair, that's the best scenario. That's the best case scenario. And do you remember as a volunteer you followed with the chair? Did you do that? In the inpatient? So that's the best case scenario. And when in doubt, always get someone to follow you with a chair. If you have a patient that's not stable, that gets tired very easily, that has a lot of balance issues, it's their first time up, okay? After you get them out of the parallel bars, because that's always the safest place, right? But when you get them outside the parallel bars and you're ambulating them in the gym, you want someone to be there with the chair. So you can just go, okay, sit, elevate the legs, right? Now, if they totally pass out, generally what you'll do is you'll sit them in the chair, elevate their legs, because usually sometimes they'll just come right back as soon as they get some blood to their head. A lot of times they faint because, or feel faint because of a vasovagal reaction. Do you remember from physiology what that is? Okay? If you've ever stubbed your toe in your house, right, really hard, how do you feel? Nauseous, exactly. Feel like you're going to vomit, you feel nauseous, you feel dizzy, all right? A lot of times when you stand someone up, because of pain, they feel nauseous and they feel like they're going to faint. So that's a vasovagal reaction. More seriously is something called syncope. Okay, what's syncope? Sudden loss of consciousness. And I specify sudden, okay? They don't even say, I don't feel very good, right? They just go. And it's mostly, they're still kind of working on the etiology, but it's usually an arrhythmia, like an AFib, or a cutoff of the cerebral blood flow for some reason, okay? But they just go. Now, in a way, syncope patients, if they have syncopal episodes, it's okay because they usually put them in the chair, you elevate their legs, they're back, like, oh, what happened, okay? More serious things of why people faint are things like myocardial infarctions, strokes, TIAs, pulmonary embolisms, okay? Those are more serious things that need intervention. And so if someone faints, I mean, you don't know, right? If they have a syncopal episode or whatever, or if it's just a vasovagal response or something more serious. But you sit them back in the chair as soon as possible, okay? If you can't get a chair, you're walking down the hallway on your own, there's no chair, you pull them back on yourself. And if needs be, you sit them right on your knee. And you go, help, 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 right? Get the chair. All right? Now, don't put yourself in the situation. The moral of the story is don't put yourself in a situation where you're only by yourself. Like I said, on the stairwell in a hospital or nursing home with the door closed and you're on the steps and nobody's there. okay? Always make sure somebody's with you. We always had a rule at the hospital, and good thing, that the therapist could never be in the room alone. At the end of either the end of the day, the end of the morning, without someone else in the room. The transporters could not all be out at the same time. There had to be somebody in the room. Mr. Mitchell has a bad story about what happened when he was alone at the clinic. I have a bad story, but it's not because I was alone. I mean, luckily I had someone in the gym with me who ran and got help, who called the code, you know, and I had a physician with me, and I still, unfortunately, the patient died. But don't put yourself in a situation where you're the only one left with a patient. No matter even if they're fine, okay? Even if you're an outpatient, and they totally feel fine, and everybody goes, we're going out to lunch, and yeah, I'll catch up with you, and you have a patient there, don't do it. Because if you have to administer first aid and call 911 or the code and be with the patient, it's not gonna happen, okay? So always have someone with you. Second thing is try not to panic. Easily said, right? Not so easily accomplished. I went through the whole protocol. Patient didn't feel well. We had them in the chair. We did a 2-man lift onto the mat. I elevated their legs. I took their blood pressure. I put a facial mask on them. I ambu bagged them with the oxygen. As soon as they stopped that first breath, they started chest compressions. Okay? I was like boom, 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 boom. Code team was there in 30 seconds, and then you step back, and then you have to faint. You almost faint. Okay? Somehow your adrenaline kicks in, but you have to keep telling yourself, okay, I know this, I got this, I got this, I got this, I got this. And then when the, when the professionals get there, you can step back and then, shake and feel nauseous yourself. But you gotta follow the protocols. You gotta act immediately. Okay? So, when someone in the clinic says they don't feel well, the first thing you want to do, the first thing I do is if they're conscious, I put my finger on their pulse. And I say, what's going on? Get the blood pressure. Put my finger on the pulse. Okay? Make sure that they're sitting comfortable. Do you want some water? Sometimes it's just very minor, and then they start to feel fine. If they're not responsive, you have to do a 2-man lift onto the mat, start your chest compressions if they stop breathing, administer oxygen, on and on and on. Okay? Now, when you go to clinic in September, the first thing you want to ask is, what is your emergency procedure? And where's your blood pressure cuff? You don't want to wait until someone doesn't feel well to say, I think it's in the other room and one of the shelves. No. Okay, you walk in day one, you say, what do you guys do in case of emergency? Okay, our blood pressure cuff is here, our SATO2 monitor is here, we always call 911, or some of the outpatient clinics are attached to a inpatient hospital. We call the code team from the hospital, but make sure you're clear about what to do. Okay? Again, if your patient doesn't feel well, get the chair. If the chair doesn't come, pull them on top of you and rest them on your knee. And that's what you're going to practice today. If needs be, you can lower them to the floor. The most important thing, and some people like, total hips, you want to protect the surgical limb, right? You should try to, probably you're not going to be able to, most important, you protect the head. Because you don't want someone to crash their head on the floor. Okay? So you lower them to the floor, bring them back on you, and keep their back to you with their head up. Okay? Preferably lay them down. Unless they're seizing, then you have to roll them to the side, right? But if you have to start CPR, you want them on their back. So you lower them on their back. Okay? and just yell as loud as you can, help, 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 help. Then you go into your vitals check, right? Airway, pulse, blood pressure. Do they need oxygen? Okay? Now, when's your CPR course? Okay, so you'll learn all these things about how to manage the emergencies, but what we're gonna do today is just really try to teach you how to put your body and how to save someone from falling to the floor, okay? And then you'll learn your CPR, you'll learn your medical management when you take your course. Okay? So, Mr. Mitchell is fantastic at reinforcing your body mechanics and making sure that you're guarding patients the right way. He's gonna do his little demo, and then you're gonna do the spinal cord injury first, or the falls? Okay.
I'm gonna first discuss like stroke patients.
Okay. And then we'll talk about, you know, a lot of patients you should, you know, and not every facility does this, and I'm really a big proponent, and in the home I do this. I teach patients how to fall safely. So they don't fall on top of their cane, you know, they don't fall on top of their crutches. I teach them how to put furniture strategically around their house so they can hold on to it, or they can sit down if they're tired. When I was in the, you know, in the clinic, I would, you know, set chairs up so that they could walk 10 feet, sit, walk 10 feet, sit, walk 10 feet, sit. That's ambulation 10 feet times 3. Okay? But you always have to think about prevention of fall. Okay? In all my years, I know there's wood here somewhere.
Right there, yes.
I haven't had anybody fall. I've had people faint on me probably 50 times, at least. I was able to catch them. The scariest was probably the 18-year-old football player that fainted on the stairs, went vasovagal on me on the stairs. But I was able to hold him until my colleagues came and we did like a 3-person carry down from the steps. But you know, they were training steps like that. He was like, I don't feel very good. And out he went. And he was a big kid. But I was able to kind of, you know, hold him, and then, you know, 2 other colleagues came and we just basically lifted him and carried him down and put him on the mat, and he was like, what happened? So, but happens. But if you're prepared, it's not so scary. You just go, another one's failing. Okay, let's just get them in the chair, lift up their feet. Would you like some water? How you doing? Check their pressure, check their blood pressure. Doing okay? Yeah, I'm okay. All right, let's go. And then you have your emergencies where you have to call 911 and get them to an emergency room. Or you have to call the code team in the hospital or nursing home and have them revived, hopefully. Okay? All right, questions, initial questions. You knew this was gonna happen, right? People were gonna faint on you? What was it? You were on the train recently, right? When someone had a seizure.
Oh, shit.
Yeah. And he managed them with another person.
Person was lucky.
Person's very lucky. That person was very lucky. Because he was gone. He had a grand mal, right?
Mm-hmm.
Yeah.
Oh, shit.
I'll go into that once you finish.
Yeah. He's been in the right place at the right time several times. Somebody had a seizure here out in the hallway.
Yeah.
Not one of our students, no.
Yeah, right by the
Recently?
storage room.
About a year ago.
Yeah.
Yeah. Came into Mr. Mitchell and said, I don't feel very, I think I'm gonna have a seizure. Because, you know, people that have epilepsy, they know. They usually know when something's coming on. And she had enough sense to go in and say, can you help me? I'm gonna have a seizure. And he said, yes, I can.
Oh my gosh.
Okay, you're up.
I thought you were gonna tell my whole story. I said,
No.
I got nothing to do now.
I won't steal your thunder.
Nah, we didn't take it. Let's push these mats down because I don't want you or myself to crack.
Yeah, good idea.
Hey, Barney, you can.
Away from all obstacles.
I think, first thing I'd like to mini discuss before we go into, thank you, hey, every little granny,
Yeah,
Every little
it's
granny.
true.
yes, makes a difference.
Full prevention.
Yeah. Historically, most patients, few of them, will probably fall or pass out anywhere from 45 minutes to maybe a day before discharge.
It's true.
That's Murphy's Law. Yeah. Why? Because the anxiety starts building up in them, and whatever medical problem they came to you, however 8 weeks, months ago, it just sometimes the emotional component kicks right in, and they lose it. Because the specter of going home to their environment is very daunting. Because in most hospitals, outpatient clinics, it's a safe haven. Everything is nice and neat, out of the way, crash team, blow code routines. But when you're home, you're by yourself sometimes because you don't have a significant other. We've dealt with patients that were going back home to an environment, and during the course of their injury, whatever, they were in the process of a divorce. So can you imagine the picture? PT, doctor, PTA, you're talking to the so-called significant other like him. You know, the patient's here, you see this how he's relaxed? They're not even listening to you. Because in their mind, I ain't going home with this jerk. You know, or what happened? She's going to, a 5-star hotel, he's going home by himself. So that's why it's so important that you as a PTA connect with the PT who did the evaluation, who's working with you, and the doctor or PA. What's the home situation? How is this person going back? What's the living situation? Do they live 3 landings up on the 2nd floor, or do they live right in when you come into the door? There's, one-room apartment type thing. Where's the bathroom? As you saw with Dr. Ross when you're doing the bathroom stuff, it's dicey. So you really, as a PTA, you need to know your patient. What's the problem? It goes back to reading the SOAP notes, understanding your PT SOAP notes, post-evaluation, and sitting down, talking with the PT. What do I need to know? So there's no surprises. Because the last thing you want to happen to you, because maybe the PT is working in another department, she's on vacation, he's on vacation, the PA comes flying into you. Oh, blah, 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 what's going on? Oh, well, I don't know. The PT didn't tell me that, or I didn't know that. The worst thing a doctor or PA wants to hear is, you don't know. But they're patient. It's horrible, because the buck stops with us. So you really gotta, control that. How do you control that? By minimizing your complacency as a PTA. PT's got the same complacency too. Patient's getting ready to discharge. Oh, well done, PTA. What time's the patient? Oh, about 45, 50 minutes. Let's do one more walkthrough with them. That's when the cocky hits the fan. And then the questions come up. Well, did you read the chart? Oh, well, did you put that in the chart so I could read it? And then comes in Kevin, the PA. I don't want excuses, I want solutions. What happened? It's rough. It's rough. So you really gotta stay away from that complacency. Like, oh, everything's good, just born patient, she never fucked up and stuff. Now, but the problem is, because of what I mentioned earlier, the anxiety going home. Let's say Elizabeth is my PTA. Okay, take your shoes off. Okay, I've been working with this young lady about 6 weeks. She's trained me. My strength is like good minus. But I have a propensity sometimes just to get a little dizzy. It hasn't been diagnosed, but you know, as I said before, anxiety is kicking you up. Now I've worked with her, I walked with her. She's taught me 3-point gait, so I'm going to use a 3-point gait. This is my so-called weak side, but again, you know my strength throughout, so I'm good. I can't wait to go home. You were great. You did a good job. Good job. Why are you not talking?
Okay, because I know something's about to happen.
Oh, gee. Okay, which way should I turn?
Strong, to your right.
Okay, I just forgot. But you know, you taught me this. Yep. So, you know, I just want, this is how, see, I'm nice and easy. Oh, you know, I'm really,
I'm sorry.
No, you're sorry. It's called Jacoby and Myers will be at your door.
Okay.
Okay? See her reaction? And she knew something was happening. So let's rewind. I can't wait to go home. I'm still waiting for the doctors to fix my meds. So that's a red light for you right there.
Okay.
I don't have all my meds yet. There could be something missing, okay? Now I'm feeling a little dizzy.
Watch his head, protect his head.
Okay. Sorry. Yeah.
Okay, so that's how it happens. She's in great shape. Okay, don't make excuses. Find a solution. Okay? She's in good shape. So what happened? She You see? Because when you're dealing with the body, doesn't mean it's somebody that weighs 200 pounds. It could be an elderly lady, 92 pounds. Hi, honey, I'm going home. I'm going home. And she might even just, oh, I tripped on my camera. Your feet help me.
Okay.
See, that's called denial. That's not even complacency. That's all right. So it's not so much what Elizabeth is doing wrong. It's the way I'm. There's no, oh, spot you. Oh, I'm falling this. Oh, thank you. No, patients don't stop. Hold me. I really widen your stance structure. You know, do a little plie. Hold. Now, patients fall, they don't stop here. Gravity just goes, you can't just, now see, that's so much better. You see what she just did? I used the buzzword that she knows, but she strengthened her lower extremity stance structure. Now, homie, I trust you. See, this is the trust thing.
Cradle his head.
See? She can't right now. She'll probably slap me in the face, so this is good. This, see, I feel safe. She got me. And now she be calling, crash car, da, 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 da. So what she has to do is what she just did now. Okay, last time, before my car's waiting. Great. But how many times did it take for her to walk with me until she gets this? You have to do this first time. Numero uno. Period. End of story. Because the worst thing. There we go. The first thing you want to do, God, the first thing, day of discharge, I'm here, and I crack my skull on this. It's horrible. It's traumatic. Then you go into the bathroom and throw up. Because then, you know, there's no commercial break. There's no, okay, you know, car rental stuff. No, the doctor, the PA, your senior PT comes in, and it's just you versus them. Because the first thing, and they're always studying like that. Didn't you read the chart?
I did.
So didn't you know he had a propensity to faint?
No, I didn't read it carefully.
Okay, so where does the buck stop? Because the PT would say, well, I wrote it in the chart. I've seen it a zillion times. So you will learn as when you're working in the field, cover yourself. No more than the PT about your patient. Most likely, the probability of falling, passing out, could have a seizure. And like I said, it's anywhere from a day to 45 minutes before discharge. This, and also Murphy's Law says, PT that did evaluation is on vacation. But she's already at happy hour. And you're the last patient of the day. But, you know, the unit supervisor is there, and not often do they read the chart of their staffs, right? So, cover yourself. This is part of covering yourself as a PT. But getting back to the different type of problems of falling, all of you have a certain amount of fitness level. But the point is, you've heard this from Dr. Ross and myself since mobility. We're not talking about being like the Amazon or Arnold Schwarzenegger back in the day, but it means that you need to reassess your fitness level when you're working with patients, because the patients are looking up to you as their, wow, I want to be like him or her, strength movements. You need to master your body mechanics. Okay, Alan, put this on. You really need to master your body mechanics. Be it yoga, dance, CrossFit, martial arts, something. You need to understand your body and its limitations. My Lord, tonight. It's gonna be fun. Patients will look at you and it's wrong, but they'll look you up and down and they'll know right away it's going to be a good vibe, a good connection. So between now, past your peaks, once you get your license, if you have any type of situation with your back, your knees, something, that will prohibit you from catching a patient, holding a patient, you need to fix it. You can't think, well, I'm just going to work in a nursing home, or I'm not going to. No, it don't work that way. You go where you need a job. Period, end of story. The very place that you hated during your affiliations might be the very job that offers you a job. Then what? It happens all the time. We hear from graduates. I'm never going back to that. They don't do anything. They massage with the ultrasound. Next thing you know, they call you with a letter. We would like to offer you a job. And then you will learn the art of negotiation for your salary. That's how it works. Okay, I'm a taxic patient. Overall good strength, but because I was in a motor vehicle accident, you know, I'm left with a taxic gait, you know, slow recall, all right? So I've worked with Alan. He's taught me the 4-point gait. Now just walk and you just reiterate the 4-point gait.
All right, so I want you to move the right portion of the walker forward. Now move forward with your left foot. Now we're gonna move your right foot forward. And then the left side of the walker. All right, so now we're gonna move the, one moment.
Now you see how things were okay, and then it just went south. Now remember, I'm impatient, and I don't like mixed messages. I like consistency. Okay, again.
Okay, right side of the walker. We're gonna move it forward. Now we're gonna move the left foot forward. Now we're gonna move the.
No.
We're gonna move the left side of the walker forward. Now we're gonna move your right foot forward. Now we're gonna move the right side of the walker forward. Left foot forward. Left side of the walker forward. Now the right foot. Right side of the walker forward. Left foot. Left side of the walker. Right foot.
Right side, forget, just say right side now.
Okay, right, left,
Beautiful.
left, right.
You see the continuity? You see how he gave me more.
Simple.
Keep it simple.
All right.
Now we're gonna turn.
Okay, now we're gonna, which side do you feel?
No. I've been with you 6 weeks.
Okay.
Don't even ask me that now.
Okay, we're gonna move towards the right side.
Okay.
All right, so just want to see how we're set up right now. We'll move the right side, left, right, wait, left, sorry.
You can't do that to a patient. Okay, I'm right here. Now what? Come on, quickly.
Left,
Because my ataxia is starting to kick in.
right, left, no, right. Let's would it be possible to move back?
I'm a patient. You control me. You tell me what to do.
Right,
'Cause I'm screwed right now.
right foot backward.
Okay. Oh! That was too easy. That was very good.
That was good.
Really good. Very good. Thought I had you, Alan. Very good. Very good. Walk me down. Yeah, exhale. Right. It ain't over yet.
How's your heart rate?
Right, left, left, right, right, left, left, right, right, left,
See, once I got the sequence going,
left,
it's good.
right, left,
Don't poke me in the eye. Keep your hands on me.
left,
Beautiful.
Nice.
Good. Yeah, give him a hand.
Yeah, go.
Right, left.
I just got some kind of mixed up while I was
It happens all the time, but the more you get nervous with your client, where you make mistakes, it accelerates stuff. Because you're giving them mixed messages. And then it just goes to the brain and it just cancel out and then they fall. The way he hit it was good. It's always good to be the second through fourth person doing this. It's the first person that gets killed. But it's okay because again, there's no cookie cutter way for this. Bottom line, he protected my head. But with any type of disability, regardless if it's total hip or knee, or where they're falling, they're crashing off the concrete. Not in that. It's the control the back of the head. You don't want that clunk there. It's a terrifying sound. Terrifying.
The other mistake some people make is they put their arm around the person like this to bring them back, and then they choke the person. So always be in ready stance so you can just bring them back and go down, because
Right.
your first
Like
instinct
this.
is to kind of, put your arm across their neck. But you've got to be careful. You also have to be careful not to pull on the arm, pull on, the elbow, especially a patient
Right.
that, already has some flaccidity. But your impulse is just to kind of pull on them, but always try to maintain your key points of control. Hold at the joints.
Para, low level para, but I'm still nothing from here down. Say I'm like a T10 para. Okay, now we're gonna do a swing through gait. Swing through gait. Now before I even do the swing through gait, I've done some balancing exercise with my PTA. So he's gonna hold me in the back, hold the strap in the back, and just keep one hand on my shoulder lightly. Okay, now what I'm gonna do, because see, Brian doesn't know what I'm gonna do. So all I'm gonna do is just balancing movements. Now remember, I have the long leg braces on. We did all this in a parallel bar, so he's advancing me to both crutches. Why this? Long strands versus axillaries. I have more mobility, so if I have to fall, I can get rid of it. Sometimes the other crutches, they get stuck. So here, this affords me a way to get rid of it, or I can move it. So I'm doing balancing exercise. You got me? Now again, this, hey, look at me. Don't look at him, he's sitting on his butt. Look at him, nice and relaxed.
No, he has the other way around.
I know, but let him figure it out. Your time will come, Kevin. Now, just hold me. Now, you need to exhale.
Okay.
Exhale.
Yeah.
No, you're not. I know when UFC fighters are not breathing. Now, you're going to tell me. Now, you have me?
And these are the typical weight-bearing exercises you do with someone with a lower extremity complete lesion, because they can't feel their legs, and they've got to use their trunk and their upper body to right themselves. So you do a lot of righting reactions because they constantly lose their balance.
Dr. Kevin told you. See, I'm doing all positions of movement. Now, he got me. That's good. Now, what happens now, what I want you to do now, Kevin, just stand, I'm sorry, Ryan, stand behind me, because I'm going to put both crutches behind me.
Okay.
Now, let me go back a little, but hold me. Now, see, this is great. So I have to learn from the waist up. Okay? Now, we're going to do a swing through gait, Ryan, okay? So give me the sentence for swing through gait.
Okay.
Both legs are together, remember that.
Okay. Both knees forward. And swing through. Good. Okay, forward.
Whoa. Perfect. Now slowly push me back up. Just push me back up. More. Mas. Push me up. Okay, good. Thanks, boy. That was close, right? Okay.
Yeah. Forward.
Now, which way should I turn?
Okay.
I'm right-handed.
Turn to the right.
Okay.
Slowly. Okay, good. Okay.
No, that's okay. That's
Okay.
good. See, he innately is bumping me back up. That's okay.
Okay.
That's okay.
All right. Move forward. Forward.
Nice. Get me back up to 90. Up. 100, 270, straight. Good. It happens all the time. So you allow the patient to try to catch himself. If not, he's got me. Now pull me up. Then I keep going. Repetition. Because sometimes, back in the days, you were with the patient for 3 months. 3 months. Now with insurance stuff. Now slowly, look down over here to the right. See me with my crutches?
Yeah.
Now, with your right hand, allow me to bend. Give me some, let this. That's part of the training. That's part of the training. Now you really gotta think for a second, the type of client that you would have. You know, I talk about a lot of the X-Game guys I work with that with snowball injuries, snowboard, cyclists, skiing. But you will have that little old lady that crossed the street, slipped, you know, or fall down the stairs in her house, and she's a T5, T6. Maybe they're not able to do this. They will use a walker. So again, you got to program, okay?
Good.
Man, you're breathing hard. Sounds like a bull.
I don't want to fall down.
Hey, Professor Angle dealt with the bulls in Pamplona, so. But the bottom line, you have to know your patient with your PT, and you design the proper AD for that person. That person may never use these, but if I'm a para, X Games type guy, post UFC with a head concussion, I don't want to use a walker, so I'll use this. So again, it's a matter of working with the patient. And if I lose, you see, the synergy between you and your client has to be just right. And then from here, no big deal. I'm like, okay, you can push me up, man. I always lost it again.
Okay.
See, and you move on. Now, watch, second, good. Good, good. Joshua. I'm the same patient. Yeah, yeah. Now look at your stance and make some adjustments. It's that simple, people. You can't stand parallel. You have to have either left or right foot forward. This is more like a dance, you know, choreography between patient, PTA. He knows when I'm gonna move, he knows how to move with me, he knows how to get out of the way. Okay, you can fix it, you can move it around if you want to. I lost maybe 7 pounds so far. Since June. Okay, now you gotta A, stop shaking. You're shaking me. And B, exhale. Yeah. It's really funny. Breathing makes a big deal with this business. Right, Alan? Yeah, you're wide awake now, bro. Look at it. Wow. I see the whites of your eyes, man. Jeez. Okay, all jokes aside.
You're going to advance both canes forward. Now you're going to swing through.
Now you have to move with me. You have to move with me and move to the side because even though I'm a para, I might miss and go and fall, and I'm going right in between. All right, okay.
So,
These little things you will see right away with your patient and you. No, this is not a good place. I need to move. Okay, swing. See, you're holding. See where he is? Something's wrong. You cannot be in between my crutches. That will piss off any patient. That I can't even walk. And look, if I go back there, I'm gonna hit you in the, wheres. So you need to find a place that you're out of my way. Yeah, parents and choirs, they got a little bit of attitude because you're walking and I'm not. That's enough to piss any type of client off. Oh, I hit the. Good. Push, good. See, I purposely opened this. This is the best I can do versus walking on Van Dam, that stupid cobblestone. When's the last time any of you seen someone with crutches walking across Van Dam? Other than the girl we saw with the lost strands and the blood so booth. Yeah.
going. Now you're going to turn to your right side, slowly. Okay, again.
You're still dealing with the nature
Joanna's on
of
that
people.
crack there.
Right. You see?
That's okay.
Now, understand your personality, excuse me, the way you feel and react to patients coordinates or doesn't with your patient. Let's say, you have sort of a don't let go. You have sort of a laid back. Joe has sort of a, funky messenger, cyclist, Dennis, same. Or you work with somebody like Mr. Kevin, or Miss Melissa. So you got a mind meld with the personalities. Don't say slowly anymore. I've been with you 3 weeks.
Okay.
You always want to slow down your
I just
patients.
passed out. You're breathing like a bull. Why are you guys breathing like a bull? I'm heavy. I'm 173 now. I lost. Wait, come on. Good. Drill here, people, to take you out of your comfort zone. This is all about comfort zone.
Keep your shoes on, because we're gonna all.
You got complacency allows you to fit up and you have an accident. You can't be in denial and complacent when you're working with someone that's using AEDs. Okay, you take the camera. Jane, take the camera. Ooh. Questions, comments so far? since I have a wide base, I post CVA on this side. My strength, let me talk first. Post CVA, I have fair plus good minus strength throughout my lower extremities. But I also have sometimes momentarily loss due to, a vestibular problem, because I was in a car accident. So you got all those things? Okay, what did I just tell you?
Your failure, lower extremity, and
No, don't ask me. I told you the big three. See, this is what happens, and there's nothing against us. A doctor will come, why are you holding me? And ask you these pertinent questions, and you gotta regurgitate it. Because you know what the doctor or PA is gonna do? You're a nice girl, but we want somebody else. That's it. That's it. That's how fast this happens. So you really have to be able to program yourself to regurgitate pertinent information. Then he said, oh yeah, okay, thank you, good. You walk away, the doctor. Because maybe the doctor forgot. He's only seeing 30 patients. But this is time to discharge. So, okay, now you spot me the way you feel you should. Now again, I've worked with her about 3.5 weeks. So it's good.
You can turn the belt.
Buckles should be in the front. There you go.
Yeah. Another thing that Dr. Engel might have mentioned, if you're working in a certain acute area or spinal cord area, part of your orientation, other than knowing where the AD devices are, you need to know where the belts are. Most likely, if you visually don't see it, they're probably in the storage room. And then you ask, by the way, and they'll tell you right away, oh, we don't have it. Okay, move on. So that's already telling you yellow light, okay, body mechanics. And then you read the chart, patient needs ×2 therapist PTA for ambulation. And so it begs the question, why is she walking me by herself? See, this is how you gotta think, but you have to be able to professionally speak to your CI or your PT right there. See, you need to be able to verbalize your fears. Don't keep it in, keep it in. You're afraid you want to ask a question. The very question you don't ask, Murphy's Law again, my friend, that's the very question that's going to get you fired because you've missed something. Okay, enough talking. Okay, let's end. Okay, what kind of gait should I use that you've taught me?
3 point.
Okay, give me the,
Okay, so push your cane forward and left leg. Sorry, right.
oh boy, see, it's going downhill already. See? It's so quick to lose your credibility, people.
Right.
I've been there. Okay. I'm not a parrot. Yeah, a parrot. No, verbally, verbal cues.
Okay, right hand with your cane. Sorry. Left cane. And
Okay, take a deep, see, everybody needs to take a deep breath. You're okay. This is good. Good training. Exhale and breathe. Tai Chi, don't work, I know. Okay, go.
okay, left hand with your cane and right leg. Left leg. Left cane. Right leg. Leg and cane.
Okay, now we're cooking.
Right leg. Left leg. Cane.
And as you go through, you just say cane, right, left.
cane.
Eliminate the leg or the foot or it's too much. Okay.
Cane, right leg, left. Cane, right leg, left.
Okay.
Cane, right leg, left.
Which way should I turn?
Okay, turn to your left. Cane.
Okay, you said cane.
Right leg. Left, cane. Right leg. Left, cane.
Oh boy, she just felt it coming. She got me now. I couldn't fall on her. Wow, that's ging. That's power. Now let me advance now.
Right leg, left, cane. Right,
right for the neck? That's a natural kind of thing.
Not the ego. You're my witness.
Are you okay?
No! She slapped me. Gotta have a little fun here, but you saw that, Ryan, right? She went, go! I told you you're too much hitting people in your class. Yeah, she got back at me now. Okay, one more time, let's go. God, things I do for my country. It's worse than Vietnam, boy. Okay, go, let's go.
Okay, cane, right leg, left, cane, right leg, left, cane.
Tell me to look up. I'm looking down too much because my head
Nice and tall,
goes,
nice
the
and
body goes.
That's right.
Okay.
Head and body reaction.
Okay.
Okay, cane, right leg, left, cane.
Nice and
right leg,
tall.
left. A forward. Okay, now turn to your right,
Turn to my right.
Yeah. Oh. Turn to your left. Okay, cane, right leg, cane,
I love to know what kind of work environment you live in.
cane, right leg, left.
Oh! Stop right here. It's okay. It's okay. I got the message. All right. Nice try. Good. All right. Where's Joanna?
She was
We'll wait for her.
She's smart.
Any questions, comments? Good. See, different